Thank you very much. I thank Dr. Bansi Sabu's team for inviting me for this talk. So I'll be talking about, can cardiovascular risk be the sole driver of diabetes medication selection? And be talking from yes. My task has been made simpler by the talks on inflammation in diabetic patients, which is pro-inflammatory state, and on the other topics, which the topic of diabetes and heart failure by Dr. Ashish Saxena. Now, if you see that cardiovascular disease is the major cause of morbidity and mortality in patients of diabetes, it is increasing prevalent and CVD is the leading cause of death in diabetics. And apart from CVD, we have a high risk of renal disease and NAFLD in diabetics, further increasing the CVD risk. If you see the spectrum of patients of diabetes, basically you can see the majority of them come with comorbidities. There was the data released for ICMR in-depth study showed that very high prevalence of pre-diabetes, diabetes, and the associated metabolic abnormalities contributing to CVD in patients with diabetes. This was a trial done by Dr. Unnikrishnan et al. And they classified diabetes patients as having very high risk for almost two-thirds were considered very high risk for CVD, and almost 90 to 95% of the patients have dyslipidemia. So you can see that this is a very pro-inflammatory, ASCVD contributing disease. Now, this was study was done in younger population, and you can see that even at below 20 years, obesity and increased LDL is very common. Beyond 21 years, you have smoking, hypertension, overweight, obesity, increased LDL-C. All of these basically are major risk factors for diabetes, and tobacco chewing compounds basically also add to the problem, which are very common in India. So type 2 diabetes is complicated by CVD, renal disease, NAFLD, and a atherosclerotic biliary basically in majority of the patients basically. If you see the diabetes with comorbidities, you can see that majority of these are associated with some of the other comorbidities. So this is like a Chandal Chokadi basically. This is not a summation, but a multiplication of metabolic abnormalities which are there in patients with diabetes, and this has to be taken in account. And if you see the statements of ESC, American Heart Association, ESD, every organization recognizes diabetes as a prone to atherosclerotic cardiovascular disease and CVD risk. So if you see the pathophysiology, the metabolic abnormalities in the form of insulin resistance, a sick fat, basically the pro-inflammatory fat, all of this develops much before development of detection of prediabetes or diabetes. So the state is favoring ASCVD even before the inception of diabetes, because before the inception of diabetes, you have insulin resistance, hyperinsulinemia, obesity, and other metabolic abnormalities which contribute to ASCVD. So, what diabetes does is that even before the development of diabetes, in insulin resistant state, you have activation of renin-angiotensin system, you have hyperinsulinemia, which contributes to excess fat deposition and pro-inflammatory fat. You have hyperglycemia, you have excess of free fatty acids, and there is a diversion of the pathway to the fructose pathway, which leads to hyperuricemia, and that also leads to a fatty liver. Also, the cardiomyocyte damage is also done before the detection of diabetes. So, coming to the common soil hypothesis, you have subintegral dysfunction, which is a universal thing which is seen in diabetic patients, and therefore this is a pro-inflammatory state. So if you see the pathophysiology, majority of the pathophysiologies, SGLT2 inhibitors and GLP-1 receptors are active basically, and they help in the pathology aspects of diabetes. So why cardiovascular risk should be the sole driver? Because if you see the studies of intensive blood sugar control, they have not shown any major benefit in reduction in CVD risk. The microvascular risk is more benefited, but the macrovascular risk is not that much benefited with the control of only blood sugars. And therefore, we are talking about screening the patients with all the risk factors for atherosclerotic cardiovascular disease and treatment of the same, basically. If you see the major trials done with DPP4, SGLT2 and the GLP-1 receptor agonist, you can see that all of these trials basically show a benefit in the cardiovascular risk profile in patients with diabetes. So these drugs are like physicians who address multiple diseases instead of being a subspecialist who address selective pathology. So these are versatile drugs which benefit not only MACE, they benefit CV death, hospitalization, heart failure, heart and renal points, albuminuria, and all-cause mortality. And therefore, the summary of benefits, if you see, then they basically are, for the positive time, I'm just going very fast. So these drugs are now the darling of cardiologists, nephrologists, even though these drugs were given by diabetologists. And if you see the AAC, basically, they also recognize that the choice of antihypertensive therapy reflects glycemic targets, ASCVD, heart failure, CKD, overweight, obesity, and NAFLD reduction. If you see this model, this is a complication-centric algorithm of glycemic control. It also reflects that these drugs should be used. If you see the ADA 2025 standards, they have given ASCVD indicators of high CVD risk, heart failure, CKD, obesity, hypoglycemia. All of these basically come into play in the reduction of ASCVD, and therefore the drug selection has to be as per the reduction of ASCVD risk. So therefore, now it is the time of a therapeutic consideration. If you see therapeutic consideration in a patient of diabetes, then the topmost therapies are SGLT2 emitters and GLP agonists, which address a CVD risk reduction in your patients. So I rest my case here because I'm running short of time. And if you see a new director or a patient, he will concentrate only on the blood sugars. But if you see a seasoned director who directs affairs very beautifully, he will concentrate on all the other people who are in background, and they are CKD, hypertension, dyslipidemia, heart failure, NFLD, and obesity. And therefore, the choice of drugs should be favoring a CVD risk reduction in your patients with diabetes. Thank you very much.
Thank you very much, Dr. Akash Singh. And now I'd like to invite Dr. Amitesh Agrawal from New Delhi. And let us see his arguments against this existing topic. Let's see how the patient exists this world without heart is failed.
Okay, good afternoon, everybody. From the onset, I will say that I don't disagree with any of the slides presented by Dr. Akash Singh, sir. In fact, he has driven home a very important point that diabetes and cardiovascular disease, they go hand in hand. Now, having said so, when we talk about the type 2 diabetes management, which is nowadays a more a personalized thing, we have two aspects of the coin. One is the physician's perspective, and second is the patient's perspective. As sir has rightly said, that cardiovascular and renal benefits of novel drugs, especially the metformin, the SGLT2 inhibitors, and GLP-RA agonist, they have shown quite a beautiful benefit as you can see from the slide. In fact, the more the risk, the more the actually the risk reduction in both the drugs and also the metformin. So there is no doubt about it. What you have said about that. Now, coming to that, now the standard of care on diabetes in 2025, I can see it also says that individuals more than 18 years, diabetes, and any one of the following, atherosclerotic cardiovascular disease or the high risk of that, you have to address all things concurrently. And they have also recommended starting SGLT2 inhibitors and GLP-1 RA. In fact, they are also considering that the risk should be directed the medication therapy. So if the patient has a higher risk, as sir has said, you should be recommending starting SGLT2 inhibitors or GLP-1 RLers. So till now we are on the same page. Now the debate or the point of debate comes when when we say that should it be the sole driver. Now here is the point of divergence. The difference opinion starts. Now let us take a look at this RSDI-ESI therapeutic wheel which was introduced in 2020. So they have considered almost 8 factors, right from the age to BMI to CKD for duration of diabetes, established CKD and finances, glycemic controls, and status and hypoglycemia. And they have suggested that you identify 2 or 3 most important concerns out of this, which you feel as a physician are important to influence your choice of anti-diabetic drug, and then identify the best choices from the outer ring. That is what the, now if you can see that they are not solely considering the cardiovascular disease as a sole criteria. In fact, they are giving a physician choice to pick and choose the factors as a personal in a patient personally which they feel are important. Now, having said so, this is just a representative study. There are many studies from across the globe. I've just picked up one which I found is representative, which are the factors that influence the choice of medication among physicians. And as you can see, they have graded among the specialists and the generalists. So there is a quite a difference. But when the people are considering the medicines, they have different thought process behind it. If somebody is using a thiazolidine, majority of the specialists are thinking that its effect on the insulin is the sole driver for choosing that medicine. So coming to the GLP-1 and SGLT2, as you can see, whenever the specialists are using it, although the cardiovascular benefits are the number one thing, which is obvious and reasonable. Again, the same thing with the SGLT2, the renal effects and the cardiovascular benefits are the major driver factors influencing the choice. But you can see at the same time, the cost is also one of the very good factors. As you can see, even the 90% are thinking the cardiovascular benefits, 75% are still looking at the cost factor also. Again, with the SGLT2, the cost is again one of the major factors they are considering when going for a choice of SGLT2 as a drug. Now let's flip it over and go to the patient preference. There's a very beautiful representation which I found, and they actually try to see the patient's choice, and they have broadly classified the patients into two types. One, patients who are survival conscious. As you can see from the graph, they are actually not concerned at all with the cost. The percentage is 0%. They are very well concerned what are the mortality risk benefits, what are the benefits in the risk of hospitalization, and what are the weight loss. So they are a survival conscious class, and at the same time there is this cost conscious class where the major driver is what is the cost, how long this low cost risk is going to be effective in me, and they are going to trade that off with the mortality benefits or the risk of hospitalization. So the cost is a major driver, and the third thing is the side effect. But at the same time, these people are also more concerned about the side effect part. And as I can say from our clinical practice, many of us will approve. In India, majority of the time you find these two kind of people. Either they will be thinking about the cost, or they will be very concerned about the side effects of the drugs you are going to prescribe. So these are the factors we need to keep in mind. So this is again a representative slide. Whenever you are interacting with the patient, whenever you come here, you learn, you take home the points, the guidelines, but end of the day, when you're sitting in a practice and a patient comes to us, it's a personalized thing. Every doctor knows his patient is different. Every patient, he has his own nicks and buts. And then there's so many factors which drive on by experience. We are just trying to spell it out. There can be at the provider level, what is your level of exposure to the guideline, how familiar with the management, how are you synthesizing the patient data, age kitna hai, morbidity kitna hai, all that stuff. Then there is a patient provider interaction, how much the trust the patient is putting into your words. He may have the same wise with you, he may not be having the same wise with you, he may trust your word, he may not trust your word. And again, the patient and the caregiver, the attendants who are along with them, they are also playing a very important part in what is getting grasps inside the patient. So as I said, there are multifactorial influences of the choice, as I exemplified: patient factor, physician factors, medication factors, and other factors. So coming back to the standard of care in diabetes slide, as you can see, recommendations said use SGLT2 inhibitor or GLP-1, but the flowchart again went to the same, discuss the patient clinician preferences and priorities. Now this is a very important line. And then it said you can do it, do it. If not, then don't do anything. No additional action taken at that time. You have to stop, reassess. So again, if you go by the summary of that, a holistic, multifaceted, person-centered approach, which is recommended for the treatment of diabetes. And the treatment decision must consider the tolerability, side effect, complexity of the medication plan, and the individual's capacity to implement it. These are the factors which are equally important. So I will just like to end this one, that what the patient's pharmacotherapy choices and treatment priorities are, and what are the clinician's priorities are, they are more often than not are not aligned. So whenever you are going for the treatment, ask, does the available guideline apply to this individual? And yes, has the management plan has been optimized as per the guidance? But at the same time, does the therapy need to be modified for the personal reasons? That is very important. Thank you so much.